Thank you. I must thank Dr. Rao and the organizing committee for the kind invitation for me to come here to speak at this your live conference. And the topic of this morning is ovarian stimulation at different phases of the menstrual cycle. Is it flexible? Then my answer, yes, it is flexible. So how do we do it? Now, ovarian stimulation, we know we may do it for assisted reproduction, we may do it for fertility preservation, and in assisted reproduction, if oocyte embryo cryopreservation is intended, the process may come well planned, or it may come difficult to plan, as in long cycles patients, PCO patients with long cycles, you don't know when, in fact, it's appropriate to start. Or the patient comes with a very tight schedule. She flies in with 2 weeks, and then she must be out again. And then in fertility preservation, there may be elective patients who think that, oh, age is getting on, and yet there is no plan for marriage or pregnancy, or cancer patients, and these are the unfortunate ones that come unplanned. Now, conventionally, stimulation regime starts from the early follicular phase, but due to circumstances, the regime may start from any point in the cycle apart from the early follicular phase. Say, if we start from the late follicular phase, when dominance has already occurred, we may still proceed to COS despite the leading follicle, but obviously, in such cycles, the progesterone may rise, and of course, regime-making transfer if that's intended unsuitable. Or one may aspirate the leading follicle before proceeding, and in this, ET may be possible. But if we intend not to transfer, then we can actually go on to stimulation in the luteal phase, which may be out of convenience if the patient happens to come in the luteal phase, or out of necessity, say for patients with poor reserve and one hopes to build up embryo store, or if it's a sudden demand from cancer patients. Now, studies have demonstrated that follicles are continuously available for stimulation throughout the menstrual cycle, and they appear in cohorts variable days apart, and the ovarian reserve determines the cohort size and frequency. And such follicles have been shown to yield competent oocytes and embryos. Now, follicular phase ovarian stimulation, this we all know, just the usual protocols, agonists via nasal or parenteral administration, or antagonists. And then if one intends to freeze all and perform elective FET, then we can go on. Okay, and this will be the trigger for the first retrieval, preferably with actually agonist, plus or minus a low dose of HCG. Now, it is actually recommended not to use HCG. However, it's a matter of confidence. Without HCG, I personally also feel that the eggs don't mature that well, so one may use a small dose. If the patient happens to be already downregulated, if you don't want the HCG, you may consider the LH trigger, but definitely one should avoid a large dose of HCG, like 10,000 units. So perhaps one not to use, if one wishes to use HCG, just up to 5,000 perhaps. And one must allow a gap of something like 5 days, about 120 hours, which is about 4 HCG half-lives, 30 hours each, for HCG to wash out. And one may even perform a test, you do a pregnancy urine test or something before you start, just to make sure that she hasn't actually got HCG in her system. Now, in this luteal phase ovarian stimulation, one should be watching out for small antral follicles. So actually, when one gives your trigger, if they're really very tiny follicles, you may actually give HCG because they will need a number of days to grow, and that will be your washout period. But larger follicles, about 10 mm onwards, may be luteinized by the induced Ehrlich search and ECG, so these are no good. And a higher FSH dose usually will be needed. And for your Ehrlich control, actually in the luteal phase, spontaneous search is really unlikely. This again is a matter of confidence. If one's not so confident, you may perhaps consider using the usual protocol, and if she's already downregulated, you carry on, and if she used antagonists in the beginning, you may continue use antagonists. If there are actually more than 4 eggs, perhaps use antagonists. Now, if there are 3 eggs or perhaps less, one may consider using clomiphene. Now, I shall go into this a little bit more later. Using clomiphene as a block or as an antagonist. Now, the adjuvant administration of letrozole appears to increase the sensitivity of follicles to gonadotropins and reduce the stimulation duration. It inhibits aromatization of androgens into estrogens, and the increase of intra-ovarian androgens enhances early follicular growth. And some may add MPA 10 milligrams daily to block the Ehrlich search or menses. Now, the ongoing ovarian stimulation would almost always block the coming menses. When we get to trigger for the second retrieval, usually we wait until, again, follicles reaching 17, 18 millimeter size. Now, this, again, one may consider using agonists or XCG. It doesn't really matter now, because after this, one actually may not go on. However, if one may actually keep going, I suppose. Now, this double stimulation during the follicular and luteal phases in the same menstrual cycle provide more opportunities to retrieve oocytes in poor ovarian reserve patients and for cancer patients needing emergency fertility preservation. For fertility preservation, let's expand this a little bit more. As in breast cancer patients, one cell cycle is about 4 weeks, and that would usually be the time between the surgery and the chemotherapy. One may consider adding tamoxifen or letrozole for protection, but better if we discuss with the oncologist regarding the tumor cell type and the chemotherapy planned. Now, this method serves as an emergency procedure for newly diagnosed cancer patients who wish to preserve fertility with COS to be performed immediately upon diagnosis. So, in 2013, I sent in a poster on this, on a conference on preservation of fertility in cancer patients. And I titled it, 2 oocyte retrievals in 1 menstrual cycle for fertility preservation. And just this is a case report. The background, a single girl of 32 years and 49 kilograms had left mastectomy in mid-October 2012 for infiltrative ductal carcinoma, and estrogen and progesterone receptors were positive. Her mother also had breast cancer at 32. She attended at end October on day 7 of her cycle, FSH then being 5.2, LH 3.4, with 2 antral follicles, both about 10 mm, requesting oocyte preservation before her chemotherapy in about 4 weeks. So I started control ovarian hyperstimulation with the starting dose of 150 FSH under tamoxifen cover, but produced only 1 mature follicle after 6 days, from which 1 M2 oocyte was retrieved on day 15. And I used triptorelin 0.1 milligrams plus XCG 3000 IU for trigger. And then on day 18, that would be 5 days from her trigger, I restarted the stimulation, and I reckon that the previous XCG dose was deemed to have dissipated. And after COH for 14 days, took a little longer, with starting dose 225 IU and later cetrorelix as antagonists, she proceeded to oocyte retrieval on day 34, yielding 10 oocytes. So there were 7 M2, 3 GV that by the following day with IVM produce 2 M2 and 1 M1. So a total of 11 oocytes from 2 retrievals within 28 days of the same menstrual cycle were cryopreserved by vitrification. So the comment then was folliculogenesis occurs throughout the cycle. COH may be conducted in the luteal phase when there is time constraint. And I will go on to show an example of this double stimulation depends actually on a number of waves of follicular recruitment in a cycle. So you can see, and this is by Bearwall in 2012, and this is one menstrual cycle. And this is one menstrual cycle up to here. And one can see that this, taking this to be the dominant follicle ovulating, however, there are 2 or 3 waves of folliculogenesis from which mature oocytes may be obtained. See about 3 waves. And the following is Huang's Shanghai protocol published in 2014. And then he would use clomiphene and letrozole to start off, and then HMG 150, and then this would be the agonist trigger and retrieval, and he can actually start right away, following by 2 to 5 units without a gap because he used only agonists, but letrozole would go on to until the follicles get to about 12. He would then stop, and here again agonist trigger and retrieval. And he actually got more oocytes from the second phase of stimulation and retrieval than the first phase. He actually had about double the amount of oocytes. And he said one can do this in the interest if one is interested in oocyte and embryo accumulation. Now this is another example of a dual stim by Ubaldi, 2016. Now, he would actually use a similar dose, the same dose, 300, for both follicular and luteal stimulation. And you notice with agonist trigger retrieval, he would still stop for a few days, presumably to watch out for appearance of antral follicles. And then he would go on and then trigger and retrieval again. And then for his study, he looked at the number of outcomes, the number of oocytes, and whether they are mature, and then the fertilization rate, and how many went to blastocysts that can be biopsied, and the number of euploid embryos obtained. The differences were non-significant from the follicular and the luteal phase retrievals. So he concluded that similar euploid blastocyst formation rate there was. Now, perhaps since we talk about this, hoping to benefit patients with really poor ovarian reserve, let's talk a little on the different stages of ovarian insufficiency. Now, one, it's the compensated stage when the AMH, if you check, is low, AFC is low, the FSH begins to go up to 10, 15 units, but the cycles are still regular, plus or minus a little bit shortened. These are ones that we see quite often, and we just treat them as our usual patients. Now, when they get to the stage of the synchronized menstrual cycle, things will appear difficult. Now, when the AFH is down, AFC is down, FSH keeps going up to about 20 units per liter, and then due to impaired steroidogenesis, less estrogen, less progesterone in the luteal phase, one then gets luteal phase folliculogenesis. And then at the onset of the menses, it may be almost equivalent to day 6, 7 of the menstrual cycle, that the follicle gets to be 10 mm or more. So for this one, we have to treat with progestins or OCPs in the second half of the cycle, day 16 to 26, in order to suppress this. Now, when we get to the third stage, it's the stage of pathologic premature LH surge, when the FSH further increases to about 25 units, and then there is increase in sensitivity to the estrogen, leading to premature LH positive feedback. Now here, one may actually treat with clomiphene citrate for just the inhibitory effect, because if clomiphene would block the estrogen receptors and therefore may actually block the positive LH feedback. So clomiphene may actually be used here. Now, when one gets to the stage of suppressed follicular growth, when the FSH is really high, it's 30 units per liter or more, now it will cause downregulation of the follicular receptors. So it's almost like what we say, the eggs are fried. You don't see the follicles coming. And because once they become large enough, in fact, they go atretic. And for this one, we have to treat with E2 and clomiphene citrate. Now, let me expand this. And then for the very poor ovarian reserve patients, if one still wishes to do something about them to maximize oocyte yield, to build up embryo store for those with basal FSH increased to 30 units or more, one may actually try give them some estrogen, 2 milligrams each, from 1 tablet to 2 tablets to 3 tablets daily. Usually I would give them 1 tablet and monitor them every 5 to 8 days. And perhaps one should use urine tests rather than blood tests to monitor the LH and FSH status, because you don't really need to know too accurately how much there are, but really only need to, one only needs to be able to categorize them, whether they are above 10, 10 to 15, 15 to 20, etc. So one may actually use just urine tests because they're cheap and not having to do blood tests, and the results are immediate. And then, of course, you see, if you see no follicle, you let them, and the FSH is still high, you give them more estrogen and then monitor again. And of course, if one goes on long enough and without seeing a follicle, you may then just complete the cycle, give her progestogen for the rest of the cycle, and then restart. However, if you see a follicle, then you have to learn how to juggle with the size of the follicle and her estrogen administration. You can drop her estrogen and then watch the follicle grow. But of course, you see, once the follicle, you also have to be aware that if the follicle grows to a certain size, your body may start to surge. So you will put in your usual antagonist or just use clomiphene. Some learn to play with clomiphene here. It will be good because there's only 1 egg. So if you actually get to see 1 egg and see what you can do with it, remember, one should keep going in consecutive cycles, because 1 follicle may bring on others. So if you don't see a follicle, things may be quiet for a long time, but once a follicle starts, it may keep bringing up follicles if you keep going. So, ovarian stimulation at different phases of the menstrual cycle. I would say yes, it's flexible, and if you know how to do it, you may avoid certain cycle cancellation even. And thank you for your patience.